If you're a healthcare professional interested in the treatment of small veins by sclerotherapy, or if you're interested in the treatment of truncal reflux and varicose veins by foam sclerotherapy, you're in the right place. Today I'm going to talk to Steve Tristram. I don't know anybody who has been treating these sorts of veins for longer than Steve Tristram. And over the years, he's developed a wealth of experience, which he's going to share with us today. And I'm going to ask him about microsclerotherapy, foam sclerotherapy, how he does it, what's the aftercare, any tricks or tips, any techniques that he uses for compression. And at the end, I'll ask him for his number one tip about how to learn these techniques. So without further ado, let's get started. Okay, well, Steve, I think we first met, my recollection is that we first met in 1995 when I was a newly appointed consultant, having finished my training in the NHS. And at that time in 1995, we had the option as consultants to do some private practice. And I realized, Steve, that I didn't know how to treat spider veins or blue veins on the leg. And patients were asking me for this treatment. And I can't recall how I found out about you, but I realized that there was a national expert in Basingstoke that I ought to go and see and meet and learn how to treat spider veins on the legs properly. And that's, I think, the time we first met. Now, I understand, Steve, that you had just finished as a general practitioner and you'd gone into private practice around that sort of time. Is that correct?
So in fact, when I first came to Basingstoke, which was 1971, I had this unusual job of partly general practice and partly an associate specialist when the new hospital was being built and the day unit was being designed and devised. And basically, I was asked to run a varicose vein clinic because I had an interest in it in the day unit, and it really built from there. So I ended up with about 3,500 patients. In 1994, I said I can no longer do both, so I left general practice, which was
Wow.
sad because I had a lot of people I knew very well. People still stop me and say, "Oh, you're Steve Tristram. You were my doctor," and that sort of thing. So, and I still work in the hospital. I do 2 sessions in the main hospital, largely leg ulcers, and the rest of the time in the private sector at the Hampshire Clinic.
So remind me, I think in our preparation for this meeting, you told me how long you've been treating veins by sclerotherapy, and you, on the back of an envelope, you'd worked out how many times you thought you'd injected veins. Remind us of those statistics, Steve.
Well, I first probably injected a vein as a medical student in St Andrews and Dundee. Not very many, but we were at the BAS meeting last year, and my long-standing senior specialist nurse at the hospital was putting some notes on a bit of paper, and Amy said, "I'm working out how often I think you put a needle through the skin, Steve." And I said, "What do you think?" She said, "Well, I think it's over 2 million times." Now,
Wow.
I think she said 2.2 million. Now, that is not a guaranteed figure, but it probably isn't far away. And that was based on the number of years, the number of sessions, how many people I inject. So it is quite a few.
Right. And when you first started, where did your training come from? Was it trial and error? Was it your own study of books, or how did you get started on sclerotherapy?
Well, a bit trial and error. A bit. There was a very good doctor in Dundee who was very keen on veins, and I did a little bit. I also visited some clinics. I visited a clinic in Strasbourg run by his son runs it now, and I've now forgotten his surname, but that taught me a lot. And then several clinics in France. I visited other places, and basically trial and error, just learning more and more about it. Philip Colbury Smith was very useful because he basically taught me how to scan. I mean, I knew the anatomy of veins pretty well, but the first scanner we had was 1993. So February of 93 was the first time I put a scanner on a leg.
Wow.
So,
And those were the sorts of scanners that you wheeled around on a trolley.
well, no, even bigger than that. They were sort of the size of a large filing cabinet. They were huge and not
Yes.
very good.
No, no. The technology has really changed. So tell me, Did you start off with small veins first and then gradually get bigger and bigger, or was it the other way around?
I would say I started with smaller veins. I mean,
Yes.
more than just spider veins. I started with smaller veins, and in those days I used to put a lot of little injections in with a compression band, and then that changed hugely in 2000 when foam was first used, and I visited Spain. So
Juan Cabrera.
Juan Cabrera, yes, now
Juan
living in
Cabrera, yeah.
Panama.
Is he?
He took his millions to Panama. So I think he's still there.
Right.
Nice man,
Still
interesting man.
nice man. Yes,
Yeah.
interesting man. Okay. So tell me, what's your approach now to the treatment of small veins by what we call in the UK microsclerotherapy? What's your approach to that, Steve?
My approach is that if you're going to do it properly, you probably have to have ultrasound to do it really well, because a number of these small veins, especially if you see clumps together, will have a feeder vein, and that feeder vein is quite crucial. And if you can inject that, you may well treat the whole lot with one injection, and that's incredibly satisfying if you can find that. And you can't do it without an ultrasound. And I know that's difficult; they're very expensive, and it's a skill that people are probably slightly frightened of. But if you have now, there's things that help a little. They've got these lights now, these ultraviolet light, infrared lights. I haven't used one for ages, so the name escapes me. But they are partially helpful. But feeder veins can be 1.5 centimeters below the skin, and the veins that those ultraviolet light or infrared lights show up are really just under the skin. So it's not ideal. But you should be aware that an awful lot of veins have feeder veins.
Right. Now, what do we mean by feeder veins? Do we mean reticular veins up to 3 millimeters in size?
Yes, 3 or 4 millimeters at the most. They can be down to 2, and once you get reasonably skilled, you can get into 1.5 to 2 millimeter veins. And if you do get in, and I think I don't remember missing now. I do so many. It's very satisfying if you see the foam going, and it has to be used with foam because the foam makes the injections very visible. And
Yes.
if you see the foam going through that, it's hugely satisfying for you and the patient.
Right.
And that would
Well,
require a compression afterwards. A certain amount, not very much.
right. Okay. Well, that you've stated quite categorically now that to treat leg spider veins, telangiectasias, veins up to 1 millimeter in diameter in the skin, you have to have ultrasound
To do it really well.
to do it
I
really well.
Yeah, no,
Now,
particularly for clumps.
for clumps of veins, yes.
Mm.
What about scattered veins?
I think scattered veins, you can do that. I mean, basically, as long as your technique is good, as long as you're confident you can get into the vein without really causing any bruising, because bruising should be, if you see bruising, that's generally speaking poor technique, because a clean technique into the vein shouldn't bruise. It'll mark the vein, but bruising shouldn't occur. And I think there's no harm in doing it. I mean, if it's not working, either you've got the wrong chemical or you're missing something feeding them. But it's a pretty painless technique done well. So there's no harm in trying, as long as you're honest to your patient and just say, I'm not absolutely certain, I don't have a scanner. And I'm not criticizing people who don't have scanners, because they're very expensive
Yes.
and there's quite a
Yes.
skill to them. And a lot of there's several nurses not far from where I work who I know are very good at injecting them, and occasionally they'll send them to me for a scan, and I'll say, look, there's no feeder veins, you can continue. So I don't have any antipathy to people who can't scan, because that's life.
No. No. Okay. So would it be appropriate then to say that for what appear to be telangiectasias and reticular veins, one can treat the feeder veins with a transillumination device such as a vein light or with
Yes,
an infrared, yeah, and
it gives you a
unless,
reasonable idea.
yes, yes, okay. And now, up until recently, I would say personally that liquid sclerotherapy is the sclerosant of choice for spider veins and reticular veins. And certainly that's been in the guidelines until recently. But there's been a recent paper, which I'll put a link to in the description, which has now suggesting that foam sclerotherapy and liquid sclerotherapy can be used either for reticular veins or spider veins, and the choice is left to the individual. Now, was it your practice until recently to use liquid, Steve?
I've increased. I still use occasionally liquid. I'm not quite sure if I've got a clear reason as to why, but since the advent initially when foam was being used, I had access to quite a clever little filter which allowed you to make quite
Oh,
good
yes.
foam,
Yes.
and there was a Braun 5 micron filter which made reasonable foam. About 2 years ago, a Spanish company called from Barcelona produced a device called a Varixio, which I think sent you
Yes.
a picture of,
You
and
have. Yes.
that makes fabulous microfoam to the extent that in the last 2 years I've hardly used liquid, and I used between a quarter and a half percent of ethoxysclerol, and you can dilute it with saline, and that will in the Varixio gives you very beautiful microfoam. And the microfoam the bubbles are so small, they travel a long way through veins. And you've got to be slightly careful you don't do too big an area. But it's sort of changed my practice to using foam virtually all the time,
Now,
of
what?
various strengths.
Yes. So, is your sclerosant of choice now is ethoxysclerol? Is it, Steve?
Yeah, well, that's the one that, it used to be ethoxysclerol from Kreuzler, and I think now that with Brexit gone, I think they're the ones that is the easiest to buy.
Yes.
We used to buy it through Ferndale. Now it's through someone else.
Yes.
The pharmacies in both my private practice and the hospital buy from somewhere, and I don't know where it comes from. But it comes as a half, 1, and 3% ethoxyclerol.
Yes. And you would dilute that down with normal saline to 0.25%.
Yeah, if it's for very small ones, very people with very fine skin, with very pale skin, where if you want to avoid marking, it's better to use a very mild solution first, and often it works. So rather than going for anything too strong, it can leave marks, which is the least popular bit of
Yes.
sclerotherapy.
Yes. Yes. So, one of the objections in the past to using foam sclerotherapy was that the foam sclerosant made with the Tessari method was such that it would degrade when injected through a 30 gauge needle.
Yes, because the bubbles were
Is
too small. The
because
bubbles were too
the
big.
were too big. But you're
Mm.
saying now that by injecting the foam made with the Varixio equipment, you can inject confidently foam through a 30 gauge needle.
Yes, you can. I don't want to be too critical. The Tessari method made a froth. It didn't
Yes.
really make a foam. It was a froth, and basically, if you injected bigger veins, you could see the froth trickling along the bottom of the vein. And whereas foam, you see it as basically it's I'm trying to think of the right word. It's basically it stays as it sticks together, and as you see it through the vein, you see the foam traveling through the vein, and what you can actually see the vein close. Trying to description of vein that's a bit like mousse, and in fact the foam I make,
Yes.
you can make a pile about that high because it's a very
Wow.
discreet confluent foam.
Now you say that it's more like froth. I
The
recall when
the
you have
Tessari,
with the
the Tessari
yes, with the
method.
Tessari yes, with the Tessari method. Now others would say, and I would say possibly the same, is that if you had the three-way tap slightly off
I know,
and you
yeah.
had a sufficient number of exchanges between the two syringes, that you actually do get more of a foam stroke mousse rather than a froth,
I don't disagree
and
with
that
that,
you
but I
don't.
think if you compare, if you've got a Varixio machine beside you and a
Yes,
three-way tap set to be very
yes,
tight, you'll
yes,
see that the Tessari foam sort of spreads out on your table, whereas the Varixio mousse, you can get a nice little pile.
yes. Now, Steve, I know it's aesthetically very pleasing to have a nice little pile of foam made from a Varixio, but can you really say in all honesty, that there's evidence that actually that foam made with the Varixio is better and you get better results, or is it your own opinion? Because I haven't seen any publications. Maybe I've just missed them. I haven't seen
Well,
any publications telling me that the clinical outcome is better with the Varixio. Certainly, it's a very impressive little machine. And yes, it is impressive when you can make a pile of foam 2 centimeters high. And I think you very kindly sent me a video, which I'll show in this video. But does it really make a difference, Steve?
my impression is very much. Now, the Varixio has been available. I got a very early one to try, and I think it's probably been on the market now for less than a year. And I'm sure someone somewhere. I've got my revalidation in May, which is the 5-yearly thing we all have to do. And one of the
Yes.
things that the doctor who's going to do my revalidate was asking the same question you've asked me. And it's very difficult, as you know, to get comparisons and then prove it, because every vein is different. And it's very difficult you can't do veins on the left leg with one, veins on the right leg with the other. And that's the issue I have. I think it's a very difficult thing to prove, and it becomes a sort of inner sense, really, as to that's. I think I'm getting much better results. I
Right.
think quicker.
Right.
I think I'm getting more
Yeah.
satisfaction. But proving that and auditing that I think, is very difficult. Need someone
Yes.
of your skills, Haroon, to do that.
No, I don't think so. Steve, I think actually that, as you say, the treatment of spider veins and blue veins is so difficult to design a study to prove anything, and that's why there is so many consensus documents, forums in which experts get together and say, I think this is appropriate and this is not appropriate. But when you actually drill down on the literature and look at it very carefully, many of the studies are poorly designed, or the conclusions are not warranted by the numbers of people in the study. And as you say, imagine people coming to your clinic and you say, I think that foam is better, but I'm going to treat your left leg with liquid and I'm going to treat your right leg with foam. How many would actually sign up to that? They come to you as an expert and they want, in your opinion, the best treatment. So yes, I think it's very, very difficult. Tell me, just for interest, a lot of the viewers here may be nurses, or they may be doctors who are not as expert as you, and they'll be looking at the insert on the sclerosant, and they'll say that this is an off-label use. Using foam for spider veins and reticular veins is not licensed in the prescription medicine. So they would be using it off-label. And I think a lot of people would be reticent about doing that.
But the
Do you have any
license
comments about that?
I think Ferndale, in fact, got the Otoxysclerol approved. And so I think now there is it doesn't stipulate the veins. It, in fact, is now approved for use in injecting veins. It has
Full
had
stop.
approval for about 9 months, probably a year.
Ah, right.
Before that,
Okay.
as long as you recorded on the notes and informed the patient that you're
Yes.
using a chemical that I was very happy with, but it is not yet licensed fully.
Right.
We're allowed to use it,
Yes.
but you have to be aware that it's not got a full license. You weren't
Right.
committing any sins, and I have never had a complaint ever. I would say you have to be totally honest and say you do get some patients who are a little bit disappointed. You can't exclude that, and if you go into a practice like I have without being absolutely honest about the outcomes and about expecting a certain disappointment, but I have never had a cross letter, and I follow everybody up very thoroughly. If I sense that there's a certain unhappiness, I see them. I use ultrasound if necessary. If there's a bit of marking, I find that very useful. Someone's just in Hereford has just produced a solution called Fade Away. Have you heard of that? And
Yes.
it's
Yes.
supposed to reduce pigmentation. I haven't been very certain if it does. It smells nice and people like putting it on, but it's early days really.
Fade away.
I'll show
Is
you.
it one of our? Yes. Hold it up to the webcam and let's have a look.
There you are.
Ah. Oh, right. A little bit to the one side. Oh, yes. Fade away. What's the active ingredient in that
I think largely, if you read it, the active ingredient is aloe vera,
aloe vera?
plus 27 other things. It was originally used on horses, apparently, and showed that their bruises disappeared more quickly. I've got patients. I don't use it very often. It's quite expensive. But if I sense that someone's a little bit disappointed because of marking, I'll give them some fade away. I'll put some ultrasound in, and I tell people, I don't mind you being impatient, but don't be concerned, don't be anxious about it, because it will all improve. So you've got to have certain
Yes.
words. I'm very keen on using the right
Yes.
words when you're advising
Yes.
people.
Well, the other statistic that surprised me, Steve, apart from the number of years you've been treating people with by sclerotherapy, and the fact that you've done certainly over 2 million injections over your professional career so far, is that you've never had a cross letter. Now,
No.
that's extraordinary for what some would regard as a cosmetic or aesthetic treatment for many, and for a treatment such as sclerotherapy, which is not perfect. It's very effective, but it's not perfect. It won't give you a blemish-free leg.
Mm.
And a treatment which does have some side effects, of which probably marking. You call it marking. Some people call it staining. Some people
Yeah.
call it hyperpigmentation. Some people call it other things, iron deposition, hemosiderin deposition.
Yeah. If
That
people
is
ask
quite
why,
extra.
yeah. Sorry.
Yeah. Sorry, Steve. So when you see, and I think part of that, the fact that you haven't had a cross letter, is that you are a very skilled communicator, and part of your consultation process is managing the expectations of your patients.
And they get quite a lengthy bit of information, which I have to thank
Yes.
Andrew Bradbury for, because Andrew was the first person to be as thorough, and he did let me use some of his words, and
Right.
it does make quite a difference. And in fact, I'm just updating it.
Good. Well, perhaps you would kindly share that with me after you've done so.
Yeah.
I think the consultation and the information you give before you actually do the treatment is very important, and probably the reason you haven't had a cross letter. I've had some cross letters, and I'm surprised you haven't. I think it's also the way you follow the people up who you sense might be a little bit disappointed or displeased. You see them so
Absolutely.
quickly, and
Mm.
yeah, I think that's very important. What is your most common complication, would you say, Steve?
I think the most common complication, I treat veins up with a truncal size up to 9 millimeters. And I've sort of worked
Yes.
that out over years, that if you treat a trunk vein that's bigger than that, there are better techniques. So that's the theme of my practice. And interesting, I heard of a French vascular surgeon from Paris, a lady surgeon, and in her talk she used 8 millimeters. So I thought, we're not far apart, and that's just worked out by experience, really. And I think the commonest complication is that a little bit of sort of tender lumps after you've treated bigger veins, and a little bit of blood entrapment, especially inside the knee. Um, Disappointment with stockings. People, particularly men, don't particularly like wearing stockings for 5 or 6 days, which is what my technique is, 5 to 7 days. That's probably the commonest one. I did have one solicitor's letter, which I told you about, which was a lady.
Yes.
A lady wanted to know if I thought that my treatment had caused her lymphedema, and I spoke to my insurer and Medical Defence Union, who said, "Well, yeah, take it seriously." And so they said, who's the best person to advise this lady? And she went to a surgeon in Birmingham that you and I know well, who
Yeah.
told her there's absolutely no chance that injections could cause. It's not in the literature, and I never heard any more, to be honest. So that's the one letter expressing a certain disappointment, but I'm sure my injection didn't cause a lymphedema. It makes you
Right.
gain 4 stone or something. But I've seen her since, and I have to say, I've never injected her again. I said, I can't now inject you, but I see her in the corridors of the clinic, and we all say hello, and I smile.
Good. You're on good terms. You're on good terms. So if I've understood you correctly, then Steve, you would say that for small veins, you now use foam, and
Virtually, virtually universally, yes.
for any size vein, you would use foam, and you like to use the Varixio equipment to make your
Yes, I do.
foam,
Hmm.
and you would use 0.25 to 0.5% ethoxysclerol made up as foam. Do you get to choose the air to lick sclerosant
But
mixture, or does the equipment make it for you?
well, basically, they come with you get these little pods, and
Yes.
basically these are sterile. These contain sterile air, or you can get ones that contain only nitrogen. They're slightly more expensive. I don't think that makes any different foam, and I just think that the fact that this is a sterile pod, um, and it makes foam within about 30 seconds. The whisk you see inside there spins at high
Yes.
speed, and it makes beautiful. And the nice thing about it is that you don't have to keep remaking it because the machine makes it, and it then, once it's made it, it continues to spin at a lower rev, and it keeps it in good condition. So you've got several minutes, probably more than several minutes, where the foam is kept in good condition by the technique of it continuing to spin. And you can set the machine to the different strengths of chemical that you use. So
Right.
it's been very well
Excellent.
thought out. It's not inexpensive. That's the box there,
Yes.
and the pod just fits on there, and it causes it to spin. So
So
it's
from
been
one, so how
sorry.
much would it cost you to make, or how much is the equipment capital cost roughly?
Around I persuaded my main hospital to buy one for me, and I think it was £1,700. The
Right.
pods are then something like £2 each, I think. Can't remember now. I buy them quite large volumes, so um, and that's probably it does make the whole procedure slightly more expensive, but I think the quality of what you're using is much better. And I have no shares in Varixio.
No,
Uh,
no, you don't.
I don't.
No, I know you don't. I'm not.
Yeah,
No, I'm not smiling. I'm not smiling as if to, not smiling as if to doubt you. So
maybe I should get some.
it's quite an investment, isn't it? Really,
It is. Yeah.
£1,700, and that might be out of the reach of many people who are treating small veins. And in the absence of published data to say it's better than liquid sclerotherapy, I think many people would say that's an investment that's a bit too much for them.
I understand that, and I do have a big practice, so
Yes,
it's absorbable because of the numbers I see, people I see.
yes, of course. Right. What's your aftercare for small veins, spider veins, and reticular veins? Do you use compression? Do you use stockings?
Well, basically, I put a small amount of very soft cotton wool on the injection site, and we tape it in place because I think that gives you a little bit of local compression. And we use a stretchy tape, so that the tape alone is applying a certain amount of compression. And
Yes.
if I've done just a few, sometimes I do no more, but the majority of people get 48 hours of a compression stocking, and I use the Duomed range, um, which have one issue, and that is that the silicone, if they wear the silicone for too long, reacts, and you can get an allergic
Yes.
reaction under that. So after 2 or 3 days, you can't leave them any longer because a lot of people do, sadly. But the stocking itself
Yeah.
is very nice.
And I recall your advice used to be to turn the adhesive band at the top down at night,
To turn it at night if they get any irritation. Yes.
and to wipe that area clean with a flannel every
Mm,
day.
yes.
Right. Do you apply any creams after the treatment at all?
No.
No. And that would be for 48 hours, would it, Steve?
But generally speaking, um, if someone's got very fair skin, they've got blue eyes, blonde hair, red hair, and very fair skin, I think you've got to be slightly more aware that they can what I call mark. They can get
Yes.
residual pigmentation. So sometimes they have
Yeah.
that for 3 or 4 days. They'll have it for slightly longer. And often
Yes.
I will see them after 3 or 4 days and check. So
What
I
do you
see
do
them.
at 3 or 4?
I
What do you
would
do at?
remove the stocking, remove the bits of cotton wool, and just take a view as to whether it's doing what it should do. And I find that I tend to see everybody within 7 days that I've injected, especially if they've needed compression. Virtually everybody.
And I recall it used to be your advice to evacuate any coagulum. Is that still your advice?
I do. If you see any form of blood entrapment, there's no point doing it before 14 days because you don't get hemolysis. That's where the blood becomes liquid again. You get a clot to start with, and it hemolyzes at around 9 or 10 days. So at 14 days, it's liquid again. And I'm pretty thorough at that. If I think there's any, I think I'm seeing less now. I think foam doesn't produce quite as much blood entrapment in the vein. It was my impression. So I don't
Right.
think I do as much.
Right, right. And another recollection I have, and I have to say, Steve, the reason I know these things is because of your excellent presentations at the British Association of Sclerotherapy over the years. I've learned a lot from you. So forgive me if I'm telling you things that you, or suggesting things that you already do, but you might have changed this. My recollection also is that you're very keen to be very gentle in the way that you express any clot there.
Mm.
Some of us perhaps are, we press our thumbs on either side of the coagulum and we squeeze hard, but that's not your view. You're a bit more gentle.
I largely put them on the end of a 5 ml syringe and use the pressure of the suction pressure of the syringe to remove it. I think that's a nicer way. Using a 21 gauge needle, a green
Yes.
needle, and a 5 ml syringe. I think that way it's a much less uncomfortable technique to the extent many people feel very little.
Right. Excellent. Thank you. I think that's all I want to ask you about microsclerotherapy. Have I left
Okay.
anything out, Steve?
I think it's important that I personally always have an assistant with me. I don't do
Yes.
it on my own, and I don't do it on my own for two reasons. One, I think, is partly a chaperone, partly
Yes.
it can be, and I'm being quite serious, it can be quite a boring procedure if you're doing quite a number. And I think it's amazing what you end up talking about. So I think part of the skill of good sclerotherapy is interesting the patient, is amusing the patient, is getting them involved in. And it's amazing what you end up talking about. You end up talking about television programs, about Putin, about anywhere, anything. So I think the third person makes it a much safer. And I had the same person for 27 years who sadly had a fall and injured her back, and I now have a
Yeah.
new lady called Helen, and she's again fabulous at communication, and I think it's an important part.
Mm.
It's a very important part of. I think if you spend half an hour injecting and don't say a word, you won't have people coming back because
No, no, no.
you have to entertain them, and it's not. There's no real skill in that. You just have to chat away about all sorts of things.
Yes. Well, I work with a colleague who is amazing at entertaining the ladies that she injects. And I recall when, well, it's Kathy McGuinness, when she used to come to my
Oh
clinic,
yes, okay.
the chatter and the howls of laughter that used to come from the room was just amazing. And the assistants loved working with her as well. Fantastic. And I totally agree with everything you've said there. Have you ever had anaphylaxis after a sclerotherapy injection?
I've had it twice, both after sodium tetradecyl, which is why I hardly ever
Yes.
use it. I had one which was many, many years ago, and she was about 60. I've never forgotten her. She came in and she had a tiny vein on her shin that offended her when she was on a golf course with shorts on. And I put a small amount of sodium tetradecyl in, probably 1%. And I can't remember now, it's a long time ago. And she said, I don't feel very well. So I said, well, we'll just go and sit down outside. And a few minutes later, the receptionist came and said she's collapsed.
Oh
And
gosh.
I literally picked her up and went into one of the treatment rooms and said, "Get the crash trolley." And my memory is absolutely. They presented me with 1 in 10,000. I got a drip up. Quite,
Mm.
I could get needles in veins quite quickly, and they gave me 1 in 10,000 adrenaline. And I sat there thinking, is that stronger or weaker than 1 in 1,000? And one of the physicians came in, a very nice physician, a good friend of mine, played a lot of tennis with him, and he said, "Just give the bloody stuff." And it was 1 in
Yeah.
10,000. But it's
Yeah.
amazing how your mind races. And
Oh
10
gosh.
minutes later, she was absolutely fine, although we did keep her in the hospital for the night.
Of
Uh,
course.
and she was fine. I wasn't. I was almost a gibbering
No.
wreck. I thought I'd killed someone. And the next one was someone in the hospital who didn't have it quite as badly, but I've virtually never used. I don't want to ruin sodium tetraaldehyde manufacturers, but I've virtually never used it since. And I've never heard or
It's
had any form of anaphylaxis with ethoxychloroquine
no.
polydominal.
Gosh, Steve, you have been very unlucky to have two. Well, I don't know. It's given the fact that you've injected 2 million times. Perhaps it's not unlucky, but I've never been involved with an anaphylactic reaction. It sounds the most scary thing. I can imagine it's scary, and some of my colleagues make a big fuss about the fact that I'm so much. We train our staff for anaphylaxis, and we rehearse it once a year, and we're all prepared for it. Fortunately, I've never had to deal with an anaphylactic reaction, but it's very, very scary indeed. What about foam sclerotherapy now? If you're treating truncal reflux up to 9 millimeters in diameter, do you place lots of cannula? Do you have a catheter that you put in? How are you treating people with foam sclerotherapy now for truncal reflux and
Okay.
varicose veins?
Well, basically, you definitely need an ultrasound. You
Yes.
can't do it properly without
No.
ultrasound. First of all, to measure
No.
the veins. So if for veins that are quite small and fairly straight, sometimes one cannula at the knee, you can direct the foam in both directions. And the crucial bit of using foam for truncal veins is you have to get the foam the whole length of the vein, and therefore quite often I'll put the cannula above the knee and put a second one below the knee, often which you never use. But the 25 gauge cannulas I use are extremely good. They're very sharp, and people hardly feel them. I use a 25 gauge Venflon if the vein is more than 2 centimeters under the skin. And again, you don't need local anesthetic. Hurts more than the actual cannula as long as you're slick at putting it in. And if they're very tortuous, sometimes you need 3 cannulas, but I very rarely more than 2, and commonly just 1, because you can track it. You can actually manipulate or maneuver the foam, and
And so you don't use long catheters up the vein.
no,
No.
I don't think it's necessary.
Yes, right, okay. And do you elevate the leg? Are there any
Yes,
postural? Yes, you do.
I do. I basically they'll lie down, and I'll put the cannulas in with them flat, and then I'll elevate the legs to about 15 degrees, and you just wait a few minutes, because basically the veins will get smaller. And if I've got veins that are slightly, if you've got like a lady I'm seeing this afternoon, she has 2 small varixes or varicoceles, which are about 1.5 centimeters. So she's going to have worn her stockings for 5 days before she comes to see me, and I'll check the size of them. But very often they will shrink sufficiently, because you've just got to make sure you've got sclerosant around the whole inner epithelium, really.
Right. And your aim is to fill the whole length of the trunk or the
Yeah,
varix with foam.
not no closer than 3 centimeters is my rule from any junction, and I'm particularly careful if there's a large thigh perforator to make sure I know exactly where it is and control the amount of foam that goes into that. A certain amount has to. I've never had. I can honestly say I've never had a DVT after treatment. I'm very careful. They get off a couch, walk out, go for a walk around the car park, and I have never had a DVT, thankfully.
How much foam would you use? Do you limit the amount of foam that you use?
I do. I said in one leg, never more than 8 to 9 cc's. And because when you elevate the leg, the veins will get much smaller, so you don't need any more than that. And you do occasionally get people get they just feel a bit funny sometimes. I've had 2 or 3 people over the years, not many, have very, very slight chest tightness, which I'm sure is a certain amount of air. The worst complication, which I've announced regularly over the years, was my wife had a small vein on her shin, which I injected, and she had homogeneous hemianopia, which means you lose half of your vision. And to the
Yes.
extent, I said to Caroline, that's my assistant, I said, I'm going to go and find another doctor. My wife said to me, I can only see half of you, and I'd hardly injected any chemical. So walking down the corridor was one of the dermatologists, and I said, Hilary, come and do me a favor. And as she walked in, Joan said, I can only see half of you, Hilary. And Hilary said, Steve, I think you need a proper doctor. And left. Anyway, within a few minutes, that cleared. And I have injected my wife since, and she's never had it again. Who knows?
Right.
That was many, many years ago.
Yeah, I've had some migraine type reactions to foam sclerosant and liquid sclerosant, which have been quite scary at the time. And I agree with you. It's nice to have an independent opinion.
Yeah.
Now,
If anyone has a history of migraine, I turn off my
yes,
overhead lights, and they wear sunglasses, and I make sure
yes,
that they lie for a little bit longer afterwards, and that they bring their migraine medication.
yes.
I can honestly say I've not had a migraine for some years now. I couldn't
Yes.
tell you how many, but it's quite a long time. And everyone is warned that that there can be odd things. No one knows why sclerotherapy could cause eye issues. Really, it's not understood.
No, no. There used to be, many years ago, there used to be a big hoo-ha about patent ductus, didn't there? And migraine was a contraindication or an indication for a heart scan. I think we've got over all of that now, haven't we?
I think so. Well, I spent a year going up to Manchester every Wednesday they were scanning people, looking for people with a patent ductus and then having their veins injected. And the
Yes.
incidence of people in the Manchester study with Professor, the vascular surgeon in
McCollum.
South Manchester, McCullum, I said, the incidence of people with patent ductus was almost double with people with
Yeah.
varicose veins. And it
Yeah.
sort of dropped away that. So basically, you could see that some foam would go through when they took a deep breath. So
Yes.
they deliberately put pressure on the right side of the heart to cause it to cross to the left by doing a Valsalva, but
Yes.
it didn't cause any issues. So I think, and we did an
No.
awful lot of them.
So we're not worried about patent ductuses now and foam going into the brain and things like that.
I don't know because I've done so many and I've never had an issue at all.
Right. Okay.
It became
So,
well known because. Sorry, carry on.
no, go on, Steve. Sorry, I'm crashing into you.
Well, no. Basically, there was one patient and it was recorded in the American College of Surgery, I think, one of the journals, and a patient in Dublin that had a
Yes.
TIA after a
Yes.
very large volume of foam had been injected
Yes. Yes.
without duplex control. There's no outcome, but it sort of stopped the use of foam in America
Yeah.
for a year and a half and cost the
Yeah.
company about 10 or 13 million, I think, to do the
Yeah.
studies.
Yes. Yes. I recall that. Yes. Some person in Dublin who injected 60 mils, I think, of foam.
A huge quantity.
It was
And
humongous.
yeah,
Can you imagine the number of ampules that were being opened to make that amount of foam? I mean,
yeah, it was. I was doing a study on different types of compression for preventers then, and I had a phone call from someone who had been. He was an investor for Swiss, for one of the Swiss banks, and I didn't know this, but I treated his wife in this study, and he said to me, "I'm not complaining. I just want to know, have you done my wife any harm?" And I said, "I really do not believe so." And he said, "Thank you. That's all I needed to know." So anyway,
Well, there we are. So going back to foam, you would inject no more than 8 mils of sclerosant. What percentage of ethoxysclerol do you use for truncal veins, Steve?
very, very 1%. Very,
1%.
very rarely more than that. I think if I find that particularly the proximal thigh junctions haven't closed at the 1 week follow-up, I have some 3% ethoxysterol that I dilute, so it's about 1.5%. So I go
Right,
slightly strong, and I've never used stronger than that.
right. And you would elevate the leg before injection. You put 1 or 2 cannula, usually. You inject until you see spasm. Is spasm
Yeah,
the
yeah,
end point that you're looking for?
yes. You want to see basically it should go into a very tight little white ball, really,
Right,
and you know that's very unlikely not to be functionally good.
right. And then you'll see them at 1 week.
Always, yeah, 5 to 7
And,
days.
and how do you judge whether they need more sclerosant?
Well, basically, it's very, if you see if the vein is at all compressible, you're
Yeah.
suspicious, and you can see the flow. So if you're still seeing any sort of flow on ultrasound, then sometimes I say, well, let's leave it another week because this might close spontaneously. Sometimes I'll do a small injection then, and if people have got, I always warn people there's a 1 in 20 chance you might need a second injection when you come back. So
So are you
that's
saying that
about 5%.
80% are closed with one injection?
Yeah. Well, I think it's about more than that. About 1 in 20, so it's about 5% of people would need to have a second injection, and it may even be
Oh,
less than that. So
wow.
that is because I know now what to look for to know that the chance of the vein not being permanently closed, or permanently, nothing's permanent, sorry, to be
No.
securely closed, um, is very high. About 1
And
in 20.
remind us, so so at the 5-day follow-up or the 7-day follow-up, if it's at all compressible, you will re-inject.
Yeah.
And that's less than 5%.
About, yeah, less than 5%.
Wow. That is,
It's relatively unusual. I mean, I think I'm trying to think, sitting here, when did I last have to do that? And I think I injected. It was quite a big man from Winchester, and he had relatively long, quite a length of veins. He was a solicitor in Winchester who was taller than me, and I said to him, "I think it's likely you'll need a more proximal injection." So he did. So I can almost remember the ones who have needed it.
well, that's very good, isn't it? And what if it's closed at 5 days? Do you just discharge them?
No, if everything's looking good, I'll say to them, "You and I are going to have a follow up in 6 weeks' time." And if they live far away, I see people sometimes a little bit of a distance. I say, if you're not sure, if there's anything you're not sure about at 6 weeks, come and see me. If before that is anything, if you get any discomfort, etc., call me. And I get quite a lot of people sending me text, photographs online of some marking in a leg, and I've got quite good at reading whether that's something we need to do, to do or not. And if I have a lady who comes every 2 years from Cairo. That's a bit difficult to follow up, but she's a solicitor in Cairo who likes watching Mo Farah playing for Liverpool and having her legs tidied up on the way back. So
That's extraordinary. I think that's very, very high success rate at 5 days. So you'll see
um,
them at 3 months, and again, if they're at all compressible, you'll re-inject, and that's rare, is it, Steve?
that was pretty rare. But I mean, you are
Right.
talking of some people. If people have a lot of branches, sometimes they need the branches treating, especially if they're inside the knee, etc. So the trunk veins are where it's very unusual to have to re-inject. But I know a lady this afternoon is coming back. I injected her 10 days ago, and I've arranged to inject the remainder of her veins, including some small ones,
Hmm.
this afternoon. So, people with
Right.
lots of branches. Um,
Right. Okay. So to come back to your strategy for a truncal vein, or for a leg, your strategy would be to treat the truncal veins with foam sclerotherapy. The leg is elevated. Would you treat any tributaries at that same session?
Occasionally, sometimes you actually see the foam going into the tributaries anyway. So what I would never do, if I've seen foam in the tributary, I'd never re-inject. I don't put another injection in at the time because I
Right.
think you then can overexpose them to the ethoxyscleral. And if they've got sort of thread veins, flare veins in the region of the varicose, I don't inject them at the first one. Now they say, look, we'll leave those to next week. I arrange to have a bit more time for the following week, and I treat any sort of obvious thread veins because quite a number will spontaneously improve just having done the
Right.
trunk vein.
Right. Okay. How do you get those great results, Steve? What regime are you using after your foam sclerotherapy? Are you using compression? Are you using eccentric compression? Are you bandaging? How long are they in stockings for? Tell us how you manage the patient before they get up and walk out.
Okay, number one is selection. Don't treat people who really have bigger veins than you're confident you're going to close. And I have a relationship with two vascular surgeons who do endovenous laser. Merv will do open surgery and does it extremely well. So selection is very important. When I inject, basically I do use eccentric compression and I mark the branches which are close to the skin, and I'll occasionally use my rolled up bubble wrap. I don't use it
Yes.
quite so much now, but rolled up bubble wrap is quite a useful if you've got a large trunk which in a very slim leg, and that's you just roll up some bubble wrap, and I put a tuber grip, a 10 millimeter tuber grip around it, and it was my dad's idea. Sadly, my dad died a long time ago. I said to my dad was a professor of biochemistry in St Andrews, and I said to him one day, I need a very light compression. I explained what I wanted, and when I got home that evening, he got some bubble wrap and rolled it up. He said, I think that might be quite useful, and I think quite a lot of people have taken that on board.
Yes.
Thanks to my dad, he never got any. He never got any money for it.
No,
And,
no.
and cotton wool over any. I use quite a lot of cotton wool. If the skin is at all sensitive, I don't tape the cotton wool to the skin. I just put it in place as I put the compression stocking on. I've almost always used PR half bandage to uh, bandage the calf, and I go up and then come down so that the overlapping edges face upwards. So if you put a stocking
Yes.
over the top, you don't get any wrinkling, and that
Yes.
stays on for 5 to 7 days. And I remove the stocking then. I scan them pretty thoroughly, so I allow half an hour for the follow-ups. So I scan them pretty thoroughly to make sure I understand and they understand anything that there's a little bit of uncertainty if it's worked. And I now use Jobst or Sigvaris class 2 compression thigh compression stockings. I've got the thing called a Medi Butler. You've probably had one of those, which is that
Yes.
nice metal device,
Yes.
which does allow you to put the stocking on very easily, saves your fingers and thumbs.
Yes.
And then almost everybody will go into a regime of no bandaging, but the stocking stays on during the day. For elderly people, I will leave the stocking on and tell them they can bath or shower with the stocking on and just let it dry on the leg. So they'll continue to wear compression because some elderly people just can't cope
Can't take
with,
it off.
they
Yes.
can't take it off or let alone put it on. So,
Hmm.
and that's quite a common thing is for people who would be struggling. I reassure them that stockings nowadays cope with getting wet. Bandages and cotton wool don't. So
No.
so that I quite often tell people, don't worry about removing them. Just accept that just towel the stocking dry, and then it will dry on your leg within 10 or 15 minutes. And that's often very well received because it takes a lot of the hassle away for older
Yes.
people.
Yes. Yes. Great. And what's the incidence of having to aspirate any coagulum at your follow-up for bigger veins?
What 1 in 10?
1 in
About
10.
Yeah. It's a little bit of a guesstimate. It's difficult that because um, I would say I'm quite thorough. If there's any doubt at all, that's the areas that can become tender. So if there's any doubt at all, I will bring them back at 2 weeks. No point before that, as I said earlier, because of you need
Yes.
hemolysis. And I
Yes.
will be quite thorough, and I think that makes quite a difference. I think if you ignore areas that can be aspirated, you'll get more marking, you'll get tenderness, and it's best avoided, really.
Yes. Yes. Well, excellent. Well, I suspect very few people in Basingstoke are having surgery.
Well,
I
yeah,
mean,
possibly.
9 millimeters is quite big. I mean,
Yeah.
uh, and I think you told us in the preparation for this meeting that you've actually treated bigger veins by getting them to shrink with a preliminary course of
Yeah.
sclerotherapy. Tell
My
us about
God,
that then, Steve.
well, not very often, but I have a godson whose father was a very good friend of mine, was one of the orthopedic surgeons, sadly died quite young. And he's inherited a gene, and he's had two fairly big operations on his veins because he had quite big veins, and he's quite an athletic guy. And this time, it was a year and a half ago, he'd had a tendon strip done by one of the surgeons, and he came back just before Christmas with quite a significant. The junctional vein was 14 millimeters, and so and the top, the proximal bit of great venous, it didn't look as though it had been touched. And I think he's got the gene where the veins regrow very quickly.
Mm-hmm.
And so I got him to wear a compression stocking for 10 days, day and night. And when he came back in, I treated him about 10 days ago. His vein was down to about 7 millimeters, and I injected it because he basically lay down. We took the stocking off with him lying down, and I injected him, put a fresh stocking on his leg, and I've seen the result. He came back this week, and it's sclerosed extremely well. And in fact, the proximal trunk that was 14 millimeters is now about 6, and it's sclerosed. So almost to the
Excellent.
junction. In fact, it's about a centimetre from the junction, but it's properly sclerosed, so I'm not concerned.
Mm. Very good. I haven't heard that strategy before of wearing stockings prior to coming to for your treatment. I think that's something that a lot of people would be very interested in. Thank you, Steve.
Okay.
Anything else we should mention, Steve?
Uh,
Any other little tips? What would you say to people who are starting off in sclerotherapy? How do they go about learning these things now?
I've just
I
said
won't
yes to a
keep you
cop.
very long.
No,
I
no,
can tell you're
well,
very busy.
I know I'm not. I haven't got any patience for about 20 minutes. I'm fine. It was Helen asking me if I wanted a coffee. Sorry, ask me the question again. Apologies.
No, a lot of consultants now who are being appointed as vascular surgeons are not getting the amount of experience that they used to, perhaps,
Well,
certainly in sclerotherapy. What would be your advice about a newly appointed consultant or perhaps a nurse who wants to learn some of these treatments and techniques? What's your advice and tips for newbies?
well, I think because the health service have largely, certainly in my area, will not treat varicose veins unless they've had a bleed or a ulcer. So,
Hmm.
and a lot of those people probably are of an age where, in fact, interventional surgery is less appropriate for them. So I think that the latest vascular surgeon who's come to my area, they come from Frimley, but he does 2 clinics a week with me, and he's hardly ever treated a vein because they're not done. The health service, the
Yes.
health service doesn't do them. And I think the advice is they must understand the anatomy. So I think that they need. A lot of them are getting ultrasound training now. Not all of them. I've said the guy who's come in, the new one for me has had been on an ultrasound course at the University of West England, and he's obviously very good at it. And so I persuaded the hospital to buy a second scanner for him, which I think he's quite pleased about. It's that the hospital don't spend much money on me now, so they immediately bought him something because at my request, I thought was brilliant. I think that understanding anatomy, getting used to ultrasound is the most important thing. Understanding sclerosants, understanding injection techniques. it's very important. It's a different technique injecting veins. It's not like doing a blood test. Traditionally, when you do a blood test, you put the needle into the vein. You then change hands to hold the syringe, so that you can suck blood back into the syringe or use a vacuum device, whatever you're using. So you've got to learn a technique of injecting with one hand that you and I have discussed before, and you've got to be able to so you put a syringe in your pocket, and when you're at the cinema, play with it so you get used to it. I think almost you've got to get the experience. You've just got to be honest with people and say, I'm doing this. I've not done many of these. I'm learning how to do it. I'm very happy. I get about once a month, I get someone joining me. And in fact, the hospital have awful. The IT at my hospital the software is brilliant, but the technology, the hardware is way out of date. So my printer didn't work in outpatients yesterday, so I phoned IT, and the lady said, "Oh, you're Dr. Tristram. My daughter came to do work experience in your clinic last week, and she really enjoyed it. So she was really helpful, and they came around and fixed the printer. So I get a lot of people, and I think it's just experience, really.
Yes.
I mean, it's
Wow.
becoming to a certain extent, second nature for me because I've done so many. And
How many
people say,
years have you been How many years have you been treating veins for, Steve?
well, in the numbers I do now, just about 50 years. But before
50
that,
years.
I did it as when I qualified, I found that if I stood for an hour, I used to feel faint. So I knew I was never going to be a heart surgeon, and so I did my anatomy training back in St Andrews. I then did 6 months obstetric guide, but had the same situation. So I then did a GP training scheme in Cornwall, down in Helston and Porthleven. Played rugby for St Ives, which I enjoyed, and I started injecting veins in Helston College Hospital. So that's 1970.
Wow.
Thank goodness me, poor
Well,
people of Helston.
no. Well, Steve, thank you ever so much for sharing 50 years of experience, top tips there. Um, I, I, I think you've made a very good case for sclerotherapy, foam sclerotherapy, the Varixio machine. I think that's going to generate a lot of interest. I don't know if you're going to the BAS meeting in May.
I've registered an interest. I don't think you can't register till the end of January. So I,
Well,
sus-
if you
I
are
suspect,
going, I look forward to seeing you there, and we
yeah,
can have
I'm almost certainly going.
Oh, excellent. Well, I'll catch up with you in person then. Steve, thank you very much. You've been very generous with your time.
I'll
You've
give you an
given us
update
some
on numbers too.
do
A year
and
on.
send me any. All right. Thanks ever so much, Steve.